Good afternoon, everyone, and thank you for coming. We're very glad to have a friend and Hoag, excellent physician, come to our podium periodically. Dr. Vincent Nguyen is trained in hospice and palliative care, board certified. There's now a specialty for that alone. Has been with us for several years. He came as a consultant of sorts for a while, and then he became, as you'll see in his slides, director of Monarch, and then now we got him back again. The palliative care program at Hoag has advanced dramatically over your lifetime and mine. We got started in 1999, and we were given one position to take care of patients who were dying here in the hospital. And since that time, we've now grown, as of late, to a whole team of 2 physicians, board certified in palliative care. Let me comment about that. Of the many specialties that represent this audience or the whole medical field in the country, there are only 3,000 physicians that are palliative care certified physicians as a result of training or experience over time. So they're a rare bird, and we're very pleased to have 2 of them. And thanks to Dr. Nguyen's work, we'll be adding a palliative care fellowship in conjunction with UCI next month. And so it's a growing field. We went from 1 social worker in 1999 to now a team of 2 physicians, 3 social workers, a clinical nurse specialist, and the chaplain, and addressing now significant numbers of patients. With our first ever coordinator, back in 1999, we saw 50 patients the whole year. Now we're seeing patients 1,100 per year, so 80 to 100 every month is addressed by this team. So it's growing, and we're grateful for Dr. Nguyen's input. And he's going to share with us a very vital part of the care of these patients, including you and me. Where do you want to die? He's board certified in family medicine, geriatrics, and as I mentioned, hospice and palliative care. When he was at Monarch, he achieved a 5-year grant from the California Healthcare Foundation to champion POLST. We'll talk about more of that later. Implementation in Orange County. He had, for all of the physicians involved with Monarch Healthcare and the ambulance drivers and the nursing homes, got trained in advanced care planning and recognition of do not resuscitate as is requested, for example, by the patient or the family. He was a medical director, as it indicates there. He's assistant professor at UCI, fortunately based Hoag, and he's now implemented this fellowship that I described. He's produced many publications on palliative and care. The program we have here now is called CARES, C-A-R-E-S. Physicians tend to blank away from the word palliative care, thinking that means their patient is dying. And so we've changed the name somewhat to benefit the use of the team. The objectives are listed on your evaluation sheet, so please join me in welcoming Dr. Nguyen.
Thank you very much for having me here again. What I'd like to share with you, when I was asked to present on the POLST update, I thought I would create something that's a little bit more fun and tangible, in which we can discuss. And it's been a wonderful journey being here at Hoag and to be leading the charge in advancing care excellence for those who suffer some serious illness. So oftentimes people think of palliative care, we think of end of life, and we ask people about death and dying. But really, the question that we ask is, how do you want to live? And it's my hope that in this presentation, I'll take you through the journey of what we do in caring for those with serious illness, and how palliative care and the POLST are part of that solution. So, Wes, some of you may have seen this slide before. You know, about 100 years ago, life expectancy here in the United States is 46 years. People at that time around the world and here, people died relatively quickly because of either accidents or infections. We didn't have soap, we didn't have a whole lot of things, and even antibiotics, what is that? And medicine at that time was basically focused on symptom management, on caring, and on comfort. Of course, today, the statistics in 2010, the life expectancy has increased to nearly 80 years of age. But then all of us will die. 10% will die suddenly, and another 90% of the rest of us will die of chronic illnesses, of a long, protracted death. And the beauty of having science and technology advancing with us is that, we are helping people live longer, but it also raises difficult decisions. The decisions that we're discussing here is, as we give care, provide care for patients, there are times where we have to ask ourselves, are we really prolonging life, or are we prolonging the dying process and the suffering of these patients? So what do we want for our patients as clinicians, we ask ourselves? Well, we want improved clinical outcomes. We want our patients to get better. We want to prepare them. We want to reduce anxiety, take care of their depression. We want to educate them, empowering them that they know how to care for themselves, and give them the sense of control, and give the responsibility back to the patient and their family. But what often we hear from patients is, they're still afraid. They're afraid of what the future may hold. And they oftentimes will tell me, and they'll say, gee, wow, Hoag has this program. We only wish we know this program existed sooner. And as I go through the community and work with various folks in Orange County, I'm very blessed and very fortunate to be here, because there's a lot of hospitals out there, they wish they have a program of what we have here at Hoag. And I would dare to say that we got one of the best programs in Southern California. And I'm very pleased with the team whom I'm going to be introducing later. So in caring for the seriously ill, here are some of the common scenarios. Is that, we know that all of us will die. Death is often expected, but really not planned for. We see pain and suffering, and well, that's the norm. When you die, you're supposed to die with pain, you're supposed to suffer, but do you really? And there's this code of silence. Let's not use the death word because it sounds so icky. And so, we're a death-denying society. We don't want to talk about it, and we think that, with technology, we're going to help people live, but do we really? And because of the medical model of care is not about necessarily, we talk about patient-centered care, where we're evolving to, but we're still very much in the disease-centric model of care that we have here. So that makes it very unclear to us how to help patients decide for themselves what they would want, and whose responsibility is it to have this kind of conversation at the end of life. And so there's a lot of mixed and sparse medical support for people who are at the end of life. And while the effort around hospice, around community palliative medicine is taking off, and it's exciting to see the expansion, but we still have much work to be done. So as a result of some of the problems we face is, that we see that there is a decline in health status of these patients, but it's not necessary to recognize that, gee, this patient may be terminally ill. They're bouncing back and forth to the hospital 2-3 times in the last 6 months, and these patients, the nursing home and the hospital becomes their place, and these patients become, I call them ping-pong balls, where they just bounce back and forth. And a lot of these patients end up in the hospital with either sudden death, or they may have a prolonged death in the hospital, typically in the ICU or in the medical floors, shortly after they move out of the intensive care units. And we also see that, sometimes the invasive interventions that in our hope of curing and providing treatment for our patients is actually worse than the disease progression. And so there we also often see these last-minute urgency and end-of-life discussions. And this is what we do in the inpatient status. If you can ask our team, as the data have shown, when I came here in 2012, we had about 600 inpatient consultative, 600 consultations. And then 2013, we grew to over 900. And this past year in 2014, we had 1,100. But what we did share with you, though, is this is just the inpatient, but we are also collaborating and expanding our services to the outpatient arena to work with those patients who are still strong enough to leave the hospital to see us. And it's the data that I'm not going to show with you today, but I'll be happy to share this with you, is the patients who we care for in the hospital, 20% of those patients die. And this is basically a little lower than the rest of the country, where the 30% of patients who receive palliative care in the hospital end up dying. It just tells us that, palliative care gets pulled in a little bit too late. We often are seen as the death panels, but we're not. And when I first came here, when I came to see a patient on the floor, the nurse would pull me out and say, "Dr. Nguyen, I don't think you need to see this patient because this patient is not dying and they're still getting treatment." And I said, well, that is the exact reason why I'm here, is to help them with the pain and symptoms while they're going through their treatment. So the team and I, and through education and through the support of the program, we're really changing the transforming health here at Hoag and helped to move the palliative care word upstream. It's not a dirty word. It's really about caring for patients and family. It's about helping how to help them. And oftentimes they will share with patients too, where we ask the word, oftentimes these people, they grieve, they have all these guilt feelings, and I tell them this is a time of opportunities. I share with them that this is not about death and dying. It's not about giving up on life, but see this opportunity as an opportunity of healing, opportunity of saying things that needed to be said, unfinished business, to be able to say, look, I love you. To say thank you for being here with me for all these years, and forgive me for the times where I haven't been the greatest dad, wife, husband, and at the same time, this is a time for forgiveness. And oftentimes, by physicians, if what we do is if we deprive the patients and their family this opportunity of healing, we haven't fully done our job. We're trained to cure and heal physically, but we cannot forget about the emotional, the psychological. While we do care for the patient, but we also remember too that the family of these patients are part of the work who we focus on. And these are our customers and our patient base. I'm going to use metastatic cancer as an example, and this was a study published in Health Affairs in 2012. And we know that patients with metastatic cancer have a predictable progression of their disease. And Dr. Morton and his team look at the Medicare fee-for-service patients with all of whom died. They found that 60% of these patients were hospitalized in the last month of life, and a quarter of those were in the ICU. And these patients end up dying in the hospital, about 30% of them, which is, like I said, it's pretty consistent. And only a little bit half used hospice, but these patients were using hospice at a median of 8 days. With the recommendation, we know that hospice is for people with a prognosis of less than 6 months if the illness follows its normal course. So 8 days is not a whole lot of time. The recommendation, of course, is we can get at least 1 month, at least, we were able to do things and help the family and help the patient a lot more. The Institute of Medicine this year came out with a consensus report which highly support the work that we do in palliative medicine, and here are their 3 key recommendations. First is we got to establish the specialty practice of hospice and palliative medicine in the education of health professionals. And this is something that's been a pet peeve of mine, and you see I love educating. I love to go out there and share the work that I've done. And I've been in this field for 20 years, and right out of residency, because I got pulled to this because I really was so intrigued with caring for people. And it really answered why I, Vincent Nguyen, went into medicine in the first place. We all have an idea. We have all these great grandeur pieces. We reflect back upon the time when we went to medical school. We ask ourselves, why do I want to go into medicine? It was very simple for me. It was to take care of people's pain and suffering. And when I discovered hospice, I discovered palliative medicine, I felt like, wow, I struck a gold mine. And this is something I've been fortunate enough to work in this field for the last 20 years. And I plan to do this until the day I die. And hopefully that, in educating and providing care for other physicians, the younger doctors who are coming up, we can transform how we care for those at the end of life, and perhaps yours and mine. And the second piece that the Institute of Medicine recommend is we need to help our clinician to have a better communication with their patients regarding end of life and what advanced care planning, what will the future behold, and what is important for the patients and family. And the other piece is for public education, engagement about end of life issues. And I feel proud that, yes, this is something that I've been doing for the last 6-7 years actively. especially around the POLST, the physician orders for life-sustaining treatment, where I co-chair the Orange County POLST Coalition, and going out there to help educate not only hospitals, medical groups, health plans, but also go into the community and working with hospices and home health agencies, nursing homes, and other providers about the importance of having these conversations early enough in their illness. So the palliative care approach is what we do, and how do we do it? What is our goal? Our goal is really to improve the quality of life of a patient and family when they're faced with a seriousness and life-threatening illness. And our work is to prevent and relieve suffering by early identification, to assess and we treat, and I mentioned about not just the physical, but the entire person, the emotional, the psychological, and the spiritual. So it is our responsibility. This is the goal that I have for my team, and my goal is also to pass this torch to other leadership here around the hospital, various departments. We need to somehow to integrate the palliative care approach to maximize the well-being, the quality of life, and the choice and decision-making for our patient. And I'm very pleased to say that, as slow as it been, we are slowly integrating ourselves in the oncology team here at Hoag, and it's really exciting, and having the leadership here at Hoag supporting the work that we do in palliative medicine, where beginning this year, we are now granted we are the team to be called upon for all cancer patients who need cancer pain and symptom management. We are the team that the physicians will be contacting. So the 1,100 patients that I share with you will be expanded to, I believe will be expanded close to 1,500 patients this year who will be servicing. So it's really fun and watch this growth and watching the support from the physicians, the leadership, and the community. And recognize too, our responsibility is to see quality of life is impaired by, recognizing quality of life is impaired by our interventions, and having that conversation early enough to prepare the patients and families say, when is enough enough? And it's not ours to say, but it's really helping them to come up with their own solution that are consistent with their values and their preference. And we want to advocate for patients who may not want to return to the hospital. Yes, Hoag is a beautiful hospital, wonderful view, good food, and great nurses and great wonderful doctors. But the hospital is not necessarily a place where patients die. People often die, most people would rather die in the comfort of their bed, in their home. And studies have shown that over and over again. And we want to promote advanced care planning to determine what the current preference as well as the future preference for care. So who benefits from palliative care? I mean, you get all these wonderful things that you do, but who are the patients? And here are the list. And it's not necessarily just one, but there's a combination of these illnesses. And many of the health plans and medical groups that I worked with when I was the medical director at Monarch, I mean, these are the lists that we use, and we use combination. So right now, it's wonderful. I have the opportunity to collaborate with the health plan in helping them to care for the population health, to identify serious patients with serious illness who can benefit from outpatient palliative care, would be patients with at least two of these chronic illnesses and who present with functional decline. That is something that's very simple. 2 chronic serious illnesses with functional decline. You don't need to have any other checkbox or checklist. The patient have advanced COPD with heart failure and they have functional decline. That's when palliative care starts. You don't have to have cancer with metastases to receive palliative care, but we're really going upstream to deliver care for all the population. There's a lot of studies that have been published in palliative care and in the work in palliative care and oncology. And Dr. Temmel published in the New England Journal of Medicine in 2010, where they found that she and her team found that they did a random control study on 151 patients with non-small cell lung cancer. And they found that these patients end up with a better quality of life, they're less depressed, and they actually live 2.7 months longer, almost 3 months longer as a median. And so this was a huge study because oftentimes people think, well, when people go to palliative care, you're just going to give them morphine and they're going to die. It's really giving up on patient. but we found that patients actually live longer, a better quality of life. They're less depressed. They feel more supported. This is a lot cheaper than those billion-dollar drugs that may help patients live that long, but lots more side effects and toxicities. And Dr. Greer went back and took a look at the studies that were done by Dr. Temmel and published this 2 years later, that those patients who lived longer were less likely to receive chemotherapy in the last 60 days of life. And those patients who end up living longer too, they end up going on to hospice, where hospice is basically the most comprehensive type of care for people at the end of life, and they were receiving hospice longer than a week. Well, it's a move in the right direction, and the studies have certainly shown and demonstrated that, and this is something that our oncology physicians are very well aware of. And here are some other guidelines and recommendations by the American Society of Clinical Oncology. And since 2012, ASCO has recommended that patients with metastatic or advanced cancer be offered palliative care concurrent with standard treatment, concurrently, not an if or and. It's let's provide these care together, because we know that patients would get better care, better symptom management, and they will respond a lot better to their chemotherapy as well when their symptoms are well managed. And it's true. I mean, it just makes sense that patients were less likely to, wanting more chemo if their pain is out of control and they're nauseated and having diarrhea and depressed. It's they're less likely to pursue. And there are a lot of consumer advocacy out there too, and you may have heard of the Choosing Wisely. The American Board of Internal Medicine supported this, and with Consumer Reports, where we're bringing palliative care right to the consumer and saying, look, patients with cancer that cannot be cured should talk to their doctor and learn about palliative and hospice. We are still relatively well. I think this is crucial. So I just share with you how palliative care impacts a person, giving them a quality of life. But there are studies that have shown that even hospice care prolongs life. And we often think, again, well, hospice is about giving up. And I would challenge and say hospice is not about death and dying, it's about helping people live. And it does. And people who choose hospice care live an average of almost a month longer than some of those who don't. The studies have shown that patients with congestive heart failure, certain kind of cancers such as lung, pancreatic, and colon cancer, they live longer than those who didn't. Again, with better control, and then the support for their loved ones are huge. So this is a question that we started with in the beginning, the question that we ask, how do you want to live? And it is my medical opinion that when we pose this question to the seriously ill with compassion and with the right way of asking the question, I really think will change the way in which we practice modern medicine. Because I really feel that good quality of care requires treatment that are consistent with people's values, their priorities, and their preference. So what is in your black bag? As physicians, we have black bags of some way or another, and we put all sorts of things in there, syringes, stethoscopes, and sphygmometers, but talking, communicating with our patient is medicine's oldest, but it's one of the least technological tool. It's also one of the least used tools, in my opinion, for many. But if we explain the options to our patients, then patients can tell us how they wish to spend the remainder of their lives. So what happens when healthcare professionals have end-of-life conversation with patients? This was a study that posed this question because there are so many myths around having this conversation. It's an elephant in the room that patients are waiting for the doctors to bring it up, and the doctors are waiting for the patients to bring it up. Right? The doctors say, well, the longer we know that, for us physicians, the longer we care for someone, the longer we care for our patient, the more difficult it is to break bad news. It's not like we're hiding it from them, but it's very difficult on us. And we want to shield them from that. And I see that. And again, being here at Hoag for the last 2.5 years, I came in with, being an outpatient doctor for 20 years, I came in with a lot of, my own prejudice. it's toward a certain group of physicians who continue to give chemotherapy for their patients in the last weeks and last months of life. And as I worked, and I began to see the compassion that our oncologists have, and it was easy for me as an outsider to say, yeah, you're not looking at the whole person. And as I discovered that, our doctors do look at the whole person, but it's just too difficult. And one of our oncology colleague that I got the chance to work with and got to know quite well when I cared for a very young patient of his with head and neck cancer, I went and visited him, and I saw a little stream of, he was trying to hide his tear when I visited him, and he says, Vince, you don't know how hard it is for me to care for this young guy. It's like there's nothing I could do about it. It's like watching the Twin Tower fall in front of me, and there's nothing I could do. That was how difficult it was for our physicians to say, and here it is, how are we going to break this bad news to our patients? And so the studies really, I thought, was a wonderful study that was published in JAMA in 2008. It shows that people who have DNR and preferred medical treatments that focus on relieving pain and discomfort over life extending therapies. That people, when they have a DNR, they want treatments that focus on comfort. And they also found that study that end-of-life conversations were not associated with patients feeling depressed, sad, terrified, or worried. As a matter of fact, they feel glad that the doctors brought it up. They were waiting for the doctors to have this conversation with them. So I'm hoping that, as practicing clinicians and as clinicians out there, we can be empowered to say, look, our patients are looking toward us for guidance, and we just need to do it with compassion and, using the word, I'm sorry, I could have better news, but this is the situation. And I wish things were different. So only 25% of Americans have put their medical care wishes in writing. And I did share with you from the physician's perspective, and why is this so? So this is a piece I want to ask the audience for audience participation is, why do you think we're not putting our wishes in writing?
They probably think that writing it makes it more real, so they're going to avoid it.
Yes, it's the avoidance. It's avoidance of facing the fact, the truth that, someday I may die.
It seems so distant in the future that it's hard far in advance for some people.
Yep. It's not going to happen to me yet. It's happened to somebody else, but not here. And then again, we live in a death-denying society. We believe in the power of technology. So what do we see on TV? What do we see in commercials? And the people never say, you see people living longer, smiling, having sex, and it's just all wonderful. Like the Cialis commercials. Not, it's people holding hand in the bathtub smiling, and people, in cancer care. You don't see people just depressed and so forth. But because we want to make things beautiful, we have the technologies that's going to help us beat this, but we know that it isn't so. So why do we plan? And this is a slide that I share when I go out and educate the community, is that 50% of the patients or the people won't be able to participate in their own end-of-life decision. They think, well, maybe if I get sick enough, my doctors will pick this up, and then, when it's time, I got time. But the reality, half of these folks won't be able to, because some of these will happen pretty sudden with the chronic illness or the acute on chronic illness that prevents them from having that conversation. And when we don't know as health professionals what patients want, we'll always err on the side of just treat. We're not sure whether or not you want CPR or not. We just do CPR on you anyway, stick a tube down you, send you to ICU, and let the intensivist take care of it. If you haven't spoken to the patients or the family, it's very hard to predict. So we err on that side. So this brings us to the Advanced Healthcare Directive and the POLST. And all these forums really focuses on the conversation. See this as a conversation, not just a bunch of paperwork, not a check boxes to fill out, but it provides a context for which we can converse. So what's all this POLST fuzz? I mean, it's, why is Vincent and pushing this? Because conversation about end-of-life issue is an important and necessary part of good medical care. And while the beauty of the POLST, I think, is a voluntary form, we highly recommend it for people with a serious illness, for someone with maybe a year, 12 months, 18 months of life and prognosis, all those patients should have a POLST form. You know, patients who call the nursing home their home, this is where they're going to live, and this is also a place where they die. I would believe every single patient in a nursing home who lives there should have a POLST. And it also, because the POLST also provides a structure for which to have the conversation. So the POLST, again, stands for Physician Orders for Life-Sustaining Treatment. It started in Oregon. In 2009, we had our first California POLST. And in 2011, it was updated to change some of the languages to make it more succinct and less scary for people. And the reason behind the POLST is, you know, again, it gives people control, prevent unwanted and ineffective treatments, to help reduce suffering at the end of life and ensure wishes are honored. And with that said, yes, this is the idea behind 2011, but the POLST form is always evolving. And so 2014, a new POLST form came out, and people asked, why do we even need this? I mean, we got one form that's good enough. But you look at it, you look at the Advanced Directive, you look at the California Advanced Directive, there's no such one form. There's about at least 30 to 50 various forms out there that have been used. But the POLST form is something that we want to be consistent in the use in California. But the POLST is not just, it started in Oregon and we're utilizing, adopting here in California, but it's also moving all across the country in at least almost 40 states. And so we're part of this national movement, and the national team recommends that, you know, periodically we need to look at the form, see what we can update and based on the feedback from those who are utilizing it to correct some of the languages. And the guiding principle for the revision is, let's not change it just for the sake of changing, but let's make it very concrete to help people. And I plan to share that with you today. So the process, the California POLST Task Force, we solicited this, we sent out emails to about 1,500 organizations and individuals asking for their feedback. And we had about 500 return, and the POLST form that you see here has about 80 updates. Yeah, that double-sided form. A lot of work was done placed into this, and I want to share with you the final revised form. So the 2014 is a bright pink, 2011 is on the bottom. What you see here is the upper left-hand corner, EMSA. It just basically means the paramedics, 911, the emergency medical services, they own this form. They bless this form. They think it's a wonderful tool. It helps them, it helps the paramedics, help the ambulance, help the entire emergency medical team to figure out what to do for these patients in an acute situation. And what you see here, though, is, you know, a cleaning up to the language. Palliative care is about the delivery of our language and how to best say it in the most tactful way. And so what we did was, yes, we cleaned it up here. You'll see that we underlined that follow these orders, then contact physician. So this is a legal document. You follow what's on this form because it's about the conversation that was had. And the POLST, we emphasize here too that the POLST complements the Advanced Directive. It is not intended to replace that document. That's the reason why we got the Assembly bill passed, because those who are supportive of the Advanced Directive saw when the POLST came out, they're thinking, well, the POLST is going to make the Advanced Directive obsolete. So there was a provision in there that makes us say, yeah, we're not going to replace it. But in reality, in practicality, if patients don't have an Advanced Directive and the POLST is the only form that's there, and the patient who's not doing well, and instead of going through the lawyer and the various other people, the POLST can be done independently without an Advanced Directive. The beauty of the Advanced Directive, however, is that it appoints the decision maker, so that we want to make sure that that person is the true person who's going to be, who's going to be speaking on behalf of the patient if they cannot speak for themselves. So here the form is a little simplified, and what you see here between the 2014 and the 2011 form is we just switch the word around when to if. Some people feel that it's necessary. So this is what CPR is what we do if the patient has no pulse and they're not breathing. But section B of the POLST form is where the meat is. And what are some of the changes? You'll see that between the 2014 and the 2011 form is we moved the most aggressive intervention first. The feedback was, well, you want patients to, you give patients comfort measures only first. It's, people typically will pick whatever was on the first thing on the list. And I said, no, not necessary. We'll be more than happy to move it around. Because by default, we're going to be most aggressive, so we put full treatment. We moved that around. But what we did differently, though, is we had a goal. What is the goal of full treatment? Is to prolong life by all medical effective means. And while patients may want full treatment, for those who may choose do not resuscitate me, but they want to be intubated, right, because of their acute respiratory exacerbation, and we intubate these patients and they don't come off of the ventilator and they don't get better. What do? So we put this other box in here and said, you know what, let's ask that question to our patients. What if you don't get better? What if, in the hope of trying to get you well, but things don't go the way that we're hoping for? And people say, well, if there's put this in, if it's time for me to have a trach or put a hole in my neck, I don't want to live that way. And so this trial period just could mean anything. It's just, let's give it a try. Let's give it an academic. Give it a 10 days, 12 days, 2 weeks. Give me some time. Let me have a chance of fighting this. And I really think that's the beauty of medicine. That's the beauty of technology, is that it gives us time to think things through. And I said again, it gives a family an opportunity to finish their unfinished tasks. The other piece I think is pretty important here is we changed the word comfort measures only to comfort-focused treatment. Because anytime we use the word comfort measures only, it feels like I feel so restricted. So we use the word comfort-focused treatment because this is where our focus is to maximize comfort. And we explain to them what it means. And we also changed the word limited additional intervention to use the word selected treatment. Because again, the word limited sounds so limited. Here's selective. Let's talk about IV fluids, IV antibiotics. Tell me what's important to you. And just because people choose do not resuscitate or choose selective treatment, they can go back to the hospital. No one's going to prevent them from seeking the appropriate medical care. And with the 2014, in Section C, it deals with artificial nutrition. So what we did too is we moved the most aggressive, going from long-term artificial nutrition 2011, we moved it to the top. The 2014 form in Section D is pretty similar to the previous forms where, you want to make sure that you have this discussion with the patient if they have the capacity or legally recognized decision maker. And the POLST form, although it's a physician order for life-sustaining treatment, requires 2 signatures. That's the only form that I know of a physician order that requires 2 signatures. Not only that of the doctor, but also that of the signature of the patient or the legally recognized decision maker. In my series over the past several years, or about 2 years ago, I bumped into a group of Catholics who were very much against the POLST. And I was questioned, why would you be against something that is pretty consistent with the Catholic teaching? But what I discovered was, the POLST is not standardized throughout the country. So in certain states, the POLST just requires 1 signature. It's the physician's signature. And the physician theoretically can unilaterally say the patient's DNR, and you made them DNR. And so the fear, of course, for those who are patient advocate, their fear that you give too much power to one decision maker, that the doctor truly had a conversation with them, or they just make the patient DNR and make that a form that just for their own use, or just simplify the process. I'm sorry, that's not what I meant to say, but it's just, there's no check and balance. And so with the California POLST form, when I presented this to a group of the bishop and then physicians who are priests, they're very much supportive of the work that we do in promoting the POLST here. I'm just going to skip here. The 2014, this is the back of the form. It's just lots of explanation, and people can look at that. But I want to share with you another piece too, is that the POLST is just, while is a legal document. Only the English document is the legal version. But there are about 10 other versions, and Armenian, there's 2 Chinese dialects that the POLST comes in as, Farsi, Hmong, Japanese, Korean, Vietnamese. And there's also a Braille as well for those who can't see. So POLST does make a difference. So why are we promoting this so much? Share with me, what are the data, why we should be doing this? Well, this is published in the Journal of Palliative Medicine that patients who had a POLST, treatment preferences were respected 98% of the time. And 98% of the time is pretty good. The 2% was basically the patient may not wanted IV fluid or IV antibiotics. They ended up getting IV fluids or IV antibiotics, which is no big deal. But what's is really important is that unwanted CPR, intubation, intensive care feeding tubes, they didn't have it. Those wishes were followed. And what about patient preferences? Recorded a POLST was associated with place of death. What it basically says that depending on what the patient chooses in the POLST, it determines where they're going to die. So this was a study published by the Journal of American Geriatric Society in June of last year. On the POLST, if someone chooses comfort measures only, about 6% of those patients end up dying in the hospital. Those who had no POLST, 34.2% died in the hospital. Those who had limited additional intervention, this is the old form, the new one would be the selected one, it's 22.4. So we do see that patients who have had that conversation have a less likelihood, have the POLST completed with comfort measures only, had the least likely to die in the hospital. So it's important to make your wishes known. And in my conversations with patients and family, I learned to use several things that have helped me to bridge bringing up difficult conversation. I usually start out with, something like, when someone we love suffers from a serious illness, the worst thing we can think of is they're going to die. But there's something worse than dying. That is, what is that? That is dying badly, suffering when you die. And that's worse than dying. And I tell them there's something worse than that. That dying badly could have been prevented by having something in place to prevent that from happening. So when I approach patients and family that way, I found it to be a bridge to having some of these difficult conversations and to recognize that, I want to help you here. I'm here to help you. I'm here to be part of you in your journey. So here are some of the feedback patients have shared with me along the way. I've already done my will, financially, and everything's taken care of what I want after I die. So it makes sense to specify what I want done to me while I'm still alive. Other people said, I feel more relaxed knowing that I won't be leaving my family guessing. I feel more in control now that I get to decide what happens to me in the future. I like this one. It was good to talk about it with my wife, as I didn't realize she had different ideas for me. And we see this oftentimes in the ICU. The patient, the wife is the DPOA, but she had all the intent of saying, keep my husband alive at all costs. And the patient himself said, no, I don't. I said, I don't want to live that way. And I'm less scared about my future health care now that we talked about it. So with that said, I'm, on behalf of the CARES team and behalf of the, the patient who we have the privilege of caring for, I'd like to thank you for all your support and the opportunity to be here with you to share with you what we've done and what we plan to do. And again, with developing a fellowship in palliative medicine is something that we're working toward. We're bringing on an internal medicine fellow. And we're in the final phase of selecting our next set of fellows for 2016. And it's interesting that we have a couple of finalists who have emergency medicine background. They finish up their residency in emergency medicine and they want to pursue palliative medicine. And it's going to change, really going to transform healthcare to bring this right into the forefront where the patients first enter the hospital. So with that said, thank you very much, and I'm here to answer your questions.